So, next lecturer everybody knows her in Israel is Tamar Sella. She's in the Hadassah team. She's an expert in pelvic imaging. She's working a lot, writing a lot, teaching a lot, and she's focused on prostate lately. And she's been part of the team for years now. Thank you so much, Tamar.
Let's talk a little bit about prostate MRI. So I chose to begin. Oh, you know, it's IT from France. Maybe because there was a different computer here. I could talk to myself, you know. Okay, good. So I chose to begin with this little comic here. Where the urologist is about to examine the patient who asks, don't we have a different type of exam from the digital rectal exam? And he answers him, honestly, if there was a virtual prostate exam, don't you think I would be the first to know about it? So what we're going to talk about is prostate MRI a virtual prostate exam instead of the digital rectal exam? And how do we do it? What do we see? How do we use it? This one is in Hebrew, so I'm going to translate for everyone who doesn't understand Hebrew, just to understand the magnitude of the problem of prostate cancer. You know, everyone talks about breast cancer. 1 in 8 women in Israel, very common, very deadly. Well, prostate cancer is seen every year in Israel, and 2,250 men are diagnosed with prostate cancer, and 380 men die of prostate cancer yearly, annually in Israel. And that means that every day during the year, 1 man dies of prostate cancer in Israel currently. So it is a significant problem. And if we talk about breast cancer being a risk of 1 to 8 in Jewish women in Israel, the risk of prostate cancer is 1 in 12. So that's a little bit lower, but not much lower. So it's definitely a big problem and a significant health problem. And you know, the way to deal with prostate cancer is not less important than other types of cancer that we're more aware of. No, the death is not as similar. It's an older, well, you know, today, with the new treatments for breast cancer, it's not so certain. We don't have the new data because the death from breast cancer is lowering with the new treatment strategies. And also, more typically, it appears in older men versus younger women with breast cancer, but still it is a significant health problem. So in dealing with prostate cancer, imaging does not play a role in screening and detection. Screening and detection is performed using blood PSA levels, digital rectal exam, very rarely it is symptomatic. The diagnosis is usually performed with a transrectal ultrasound-guided biopsy. Now, ultrasound is not a very sensitive technique for detecting the cancer itself. Sometimes on ultrasound, in particular if you have contrast-enhanced ultrasound, you may be able to see the tumor in the prostate. But typically, transrectal ultrasound-guided biopsies are just for us to see where the prostate is and make sure that we're targeting all the different areas within the prostate when performing the biopsy. Treatment strategies, however, are very highly dependent on imaging. It makes a big difference if it's a very small tumor which isn't seen on imaging at all, if it's a tumor which is spread metastatically to lymph nodes, which we can see on CT, or on different kinds of PET scans, or on MRI, if it's a tumor which has traveled to the bones, which we can see in bone scan, or if it's a locally advanced versus a small tumor within the prostate. And for each different scenario, there's a completely different treatment strategy. So our role as radiologists in prostate cancer is not in the diagnosis, it's in the treatment planning and treatment strategy. So like we heard before, the most accurate imaging modality for any pelvic organ is MRI. And this is true for prostate as well. And what we'll talk about today is when do we perform the examination, how do we perform it, what can we see on the examination, and what are some of the limitations. So let's begin with when do we perform it. I divided the common clinical indications for prostate MRI into 2 groups, into 2 categories. On the left, we have pre-treatment staging and looking for post-treatment failure. Is there a pelvic recurrence which we can treat? And the reason I put those in one category is because these are questions which need very, very, very high resolution imaging in order to answer them. On the right, we have clinical problems which the urologists are running into more and more, such as patients with elevated PSA and negative biopsies, or patients who are planned for active surveillance, no treatment, just following them. And in these cases, we're going to discuss what our optimal protocol will be, and do we really need the very, very, very high resolution which we need for local staging. So the reason that I'm talking about when do we perform it before how do we perform it is that how we perform the exam depends on what our clinical question is specifically. Okay? So in this first case, when we need the very, very high resolution, undoubtedly we need an endorectal coil in order to answer the questions. It can be a 1.5 Tesla endorectal coil exam, which is very high quality exams. It can be a 3 Tesla endorectal coil exam, but we need the resolution of the endorectal coil in order to be able to determine whether a tumor has gone through the prostate capsule or not, and we'll see some examples later. When we're talking about elevated PSA negative biopsies, or does a patient need treatment or not, the goal of the examination is different, and what we're actually asking is there a clinically significant prostate cancer which was missed on biopsy? And we'll see that in these cases we may not need the endorectal coil in order to answer the question. So just very shortly, the most important clinical question when staging prostate cancer for local advanced versus locally confined disease is, has the disease spread outside of the prostate gland? And when the disease, even if it's multifocal and there's a lot of disease within the prostate gland, this is still stage 2 disease. And any kind or any form of local treatment, be it surgery, be it radiation therapy, is appropriate. However, if the disease has extended outside of the capsule of the prostate or into the seminal vesicles, we're talking about more advanced local disease. Surgery may be an option in select cases, but in most cases, they will opt for radiation therapy in such cases. And the reason is not just because they feel like it, because data shows us that the more advanced the disease is, the more of a chance there is for recurrence at 4 years and at 10 years. If you have seminal vesicle invasion in prostate cancer, there's a 73% chance of local recurrence within 10 years. Now show me a urologist who wants to do a radical prostatectomy with the chance of the patient may be impotent, may be incontinent, and have the cancer come back. So they choose what kind of treatment to give based on how advanced or how locally advanced the disease is. So, how do we perform prostate MRI? Let's just remember first that not everyone can have an MRI. Okay, patients with pacemakers. Today, some pacemakers can go into the MRI machine, definitely with cardiologist supervision. But in general, we say that patients with pacemakers, unless they necessarily have to have the MRI examination, it's not wise to do so. Metal shrapnel can be a big problem, and unfortunately, in particular here in Israel, with terrorist bombings and wars and so on. Claustrophobia is a relative contraindication. It can be overcome with sedation, but the truth is, and I see Shimon here in the audience who's done many, many prostate MRI exams with me, the truth is that the head is at the tip, it's just at the edge of the machine when you're doing a prostate MRI exam. And I usually tell the patients to lean their head a little bit back, and if they look out, they're going to see the ceiling of the room and not the tunnel of the machine. And I don't, very, very few patients who cannot do the specific examination because of claustrophobia, so that's not a really big one. Renal failure is a problem with contrast injection. Okay, so we'll talk about do we or do we not need contrast. And then we also need to remember that not everyone should have an MRI, and part of the problems are limited availability and the high price of an MRI. We may be able to overcome this when we don't need the endorectal coil and have more MRI machines, but as it is right now, we do need to leave the examination for the patients who will benefit from it most. A patient who has a PSA of 25 has a very, very high chance of having metastatic disease. There's no point in sending him for a prostate MRI. Start with looking for the metastatic disease. So we need to plan who it's most appropriate for. So our BFF, the same as in gynecological imaging, is the T2-weighted images. And this is an example of what a prostate looks like on axial images on T2-weighted imaging. No contrast, no nothing. And when I just started doing prostate MRI, this is all we used. axial, coronal, sagittal, T2-weighted images. And we'll see the diffusion in contrast to them added on along the way. So T2-weighted images, we can clearly differentiate two parts of the prostate gland. The peripheral zone is the zone surrounds the prostate from outside. You can see it has high signal intensity on T2-weighted images, and this is where 80 to 85% of prostate cancer develops. The central gland is in the middle, central gland. It is more heterogeneous. This is the part of the gland that grows with benign prostatic hyperplasia. This is the part which will become very heterogeneous, have nodules in it, causes lots of problems in deciding whether something is suspicious or not. However, fortunately, most prostate cancers do not develop in this region. And you can often also see the urethra running in between the two. Please note around the peripheral zone, around the prostate gland, there's this dark line coming all around, and that is the very famous prostate capsule. This is the thing that we need to see with very high resolution in order to decide has a tumor protruded beyond it or not. This is just an example of a CT and an MRI of the prostatic area, or the prostatic region of the pelvis, and notice the difference in the inherent resolution of the two technologies. With MRI, you don't need to add anything in order to see the different structures. So we can see this is the bladder in front, the rectum in back, in this case with an endorectal coil filled with air, and the seminal vesicles, which are involuted fluid-filled tubules, so on T2-weighted images they will be white. And you can clearly see the vas deferens coming in on both sides as well. And whereas on the CT it's just one big blob of gray. Here's an example of coronal image of a prostate gland with an endorectal coil and without an endorectal coil. This is the same patient. So just to show the difference in resolution between with an endorectal coil and without an endorectal coil. And the same thing in axial image. This is, believe it or not, the same patient, okay? On the same machine. This is a 1.5 Tesla machine. This is without an endorectal coil and with an endorectal coil. The patient has a very, very large tumor in the prostate gland with some involvement of the posterior capsule. And on the 1.5 Tesla, you can see there's something wrong, but you have very, very much less detail. And here's just another example of our best friend T2-weighted images. We can clearly see the prostate gland. This is a heterogeneous central gland. We see normal peripheral zone here. All of the dark signal within the peripheral zone is tumor. And in this case, there's no doubt that it is involving the capsule. But it's not only involving the capsule, it's involving the capsule in the specific region of the neurovascular bundles. The little black dots running through here is where all the vasculature and all the blood vessels and the nerves run up, and they control impotency, incontinence. And this is very important for the urologist to know when planning surgery whether they can spare or not spare this region. We need an endorectal coil in order to be able to give that information. So we're talking about the endorectal coil, and here's the problem. When we talk about a virtual prostate exam, the minute we use an endorectal coil, it's not a virtual prostate exam anymore. Digital rectal exam is much more pleasant than an endorectal coil MRI. What can I say? Okay, so this is the endorectal coil. The receiver coil sits inside this curved area and is positioned so it is laying right on the prostate through the rectum. And there's a balloon which we fill with air in order to keep it in place so there will not be any motion in any artifacts. Staging accuracy has been shown to be much better with an endorectal coil, about 81% versus 69%, both in 1.5 Tesla and 3 Tesla examinations. Just a short word about T1-weighted images. They do have a role in imaging of the prostate gland, though look again, it looks like a CT scan. You really can't see any information on the T1-weighted images, and we'll come back to that in a moment when we talk about some pitfalls. Okay, but we don't stop anymore with the T2-weighted images. Today, we do multiparametric prostate MRI, meaning we use different parameters. And by using different parameters, we're getting both anatomic information and functional or metabolic information. And the sequences that we use, like in many MRIs today, are the T2-weighted sequences as our bread and butter. Our basic anatomic imaging is the T2-weighted images, our BFF, like Anna said before, and I love that. I'm going to use it all the time. However, we do add diffusion-weighted imaging, which has been shown to be very, very, very strong tool for detecting prostate cancer, not for staging, but for detecting the tumors. And we use dynamic contrast enhanced, which sometimes works and sometimes doesn't. So like we said, the multiparametric imaging enables both anatomic and functional imaging. The diffusion-weighted basically measures the rate of the diffusion of the water molecules through the tissue, and we know that cancer doesn't enable this diffusion as fast and restricts the motion of the water, and dynamic contrast shows us the malignant neovascularization. Like we said, less extracapsular space means less motion, like when we have a cancer. This can be measured on MRI quantitatively, or can be seen as a picture qualitatively. And what we usually look at, though we can measure the diffusion coefficient in each case, what we usually look at is what we call an ADC map, which takes different diffusion evaluations, puts them into a qualitative picture where you see black is more restricted and white is less restricted. However, diffusion-weighted imaging has very limited spatial resolution. It's much better on 3 Tesla than on 1.5, but still limited spatial resolution. Usually around 7 millimeters is the minimum of where we can see restricted diffusion. And we need to keep that in mind. Maybe when and if we move to 7 Tesla machines, we'll be able to do it much better. But as of now, it's very accurate for detection, not very good for staging. And here's a meta-analysis of almost 6,000 lesions which were evaluated, which compared T2-weighted imaging, diffusion-weighted imaging, dynamic contrast imaging, or T2-weighted with diffusion imaging to show the sensitivity for depicting, for showing the cancer. And you can see that the diffusion-weighted imaging was more specific, was more sensitive, and more specific with a better area under the curve than any other single sequence that we could use. However, the best performance, or the highest sensitivity, just a little bit higher, was addition of the T2-weighted and diffusion. So what I usually say is diffusion-weighted imaging is prostate for dummies, like the series of books, wine tasting for dummies and so on. You look at the diffusion-weighted imaging, it's going to direct you where the tumor is. Then you go with that over to the T2-weighted imaging and look at the structures around and look at the anatomy around where you already know that the tumor is from your diffusion-weighted imaging. Dynamic contrast enhancement shows us the vascular characteristics of the tumor, and we know that malignant lesions have more blood vessels, but what we need to remember about dynamic contrast enhancement in the prostate is that the prostate gland is a very vascular organ in itself, and it enhances rapidly. So this really needs to be very dynamic contrast enhancement. We need to get the first point where the tumor enhances a little bit before the rest of the prostate gland. Because once the whole prostate gland enhances around, you won't be able to depict the specific areas which are enhancing stronger and so on. So here's an example where dynamic contrast enhancement helps us. This is a prostate gland after radiation therapy. And what radiation therapy does to the prostate gland is loss of the peripheral central contrast. The whole gland becomes very dark. We don't have the high signal of the peripheral zone anymore. The whole gland becomes very, very dark and very uniform. And if you don't have the high signal of the peripheral zone on T2-weighted images, you can't find the low signal tumor within a low signal peripheral zone. So in these cases, contrast can help us very much. By the way, diffusion doesn't work in a post-radiation prostate either, because it's all very fibrotic. So here's an example just where we barely see anything on the regular T2-weighted images, but can clearly see the tumor, the recurrent tumor, enhancing very strongly. So like we said, contrast may help in problem cases, but it must be very dynamic. Now, one thing which we've learned over time is that not all tumors enhance. So if you have suspicious diffusion with a suspicious T2-weighted imaging mass, but it doesn't enhance on the contrast enhancement, that doesn't mean it's not a cancer. We don't know why yet. We're initiating a study now to try and check all sorts of things which may affect it. We know it's not the aggressiveness of the tumor. Okay, so remember to use it with caution in patients with renal failure. And just another example of a prostate gland which on T2-weighted images looks perfect. Beautiful peripheral zone. Here's the urethra, here's the central gland, but after contrast enhancement, a very small tumor shows up here, which we didn't see on the T2-weighted images. Okay, so using the different sequences that I've described, and mostly the T2-weighted images, what can we see on a single prostate exam? This is what we can see on an endorectal coil prostate exam. Okay, so we can do tumor localization. As you can see here, normal prostate gland, urethra with some urine in it, and the abnormal low signal intensity of the tumor. On coronal image, the same tumor. And we can see if it's in the central gland as well, we often see them. We can evaluate the capsule for extracapsular extension. So here the capsule would have extended, let's go back one. This is the tumor right here. This is normal peripheral zone in an enlarged central area. And this is where the capsule would have extended, and clearly you can see the tumor extending beyond the capsule into the area of the neurovascular bundles in this case. This is not a good surgical candidate. Okay, we can evaluate, like I said, the neurovascular bundles on each or both sides. Seminal vesicle invasion can be small, like in this case, where you see the base of the seminal vesicles. We don't have that normal high signal fluid-filled tubular structure because tumor has invaded the base of the seminal vesicles, or it can be much, much larger. Here you see normal seminal vesicles on one side and a very large tumor involving the seminal vesicles on the other side. Seminal vesicle, even with very large tumor like this, are not always palpated on digital rectal exam because they may be too high up in the pelvis. So it's an important, though they are close to the rectum, but depending on how high up they are. Two other important things that we evaluate in examination are looking for metastatic disease with pelvic lymphadenopathy or pelvic bony lesions. These will usually happen in patients with higher PSA levels, but our concept here today, currently in Israel, with lack of MRI machines, is if a patient is already going to have a prostate MRI, and he's already scheduled an appointment and gotten financing from whoever for it, then we might as well do a one-stop shop examination, which will give us all the information. We never know ahead of time who will have cancer and who will not. So we're going to run a few more sequences just to look at the lymph nodes and at the bones at the same time. And maybe he won't need a CT and so on. Okay, so lymph node drainage from prostate cancer, and this is important to remember, is to the iliac lymph nodes, to the obturator, perirectal, and periprostatic nodes. Okay? Inguinal, and this can go all the way up to the aortic bifurcation. So if you're doing a sequence to look for lymph nodes, you need to start from the bifurcation of the aorta because that's where the nodes can sit. Inguinal lymph nodes are not part of the primary drainage of prostate cancer. So enlarged only inguinal lymph nodes in a patient with prostate cancer are caused from, I don't know, a problem in his toenail, but not from his prostate cancer. And MRI and CT are comparable in their sensitivity for detecting lymphadenopathy. The reason being that we use size criteria. We don't have anything better. There are a few research things going on, but we really don't have anything better in clinical practice today, so it's just by size criteria. However, though they are comparable, particularly if you know how to read a CT well, it is sometimes a little bit easier to see lymph nodes on MRI than on CT because they have very different signal intensity compared with the flow void of the blood vessels. You can see here the flow void of the large blood vessels, which is completely black, and the lymph nodes are intermediate signals, so it can sometimes be a little bit easier to see them. Another thing is on T2 fat sac, they sort of light up like a light bulb, so that can also help us detect lymph nodes. The chances of bony metastasis, like I said, raises with the PSA. If a patient has a PSA lower than 10, there's less than 1% chance that they will have a bony metastasis from prostate cancer. Okay? So, in theory, there's no point in looking at the bones in a patient with a very low PSA. And the higher the PSA goes, the more of a chance there is for bony metastasis. And of course, we can see metastasis on CT or on MRI or on bone scan. On CT, they're most commonly sclerotic, but they may be subtle and hard to define on CT, in particular when they're in the very beginning of their development. And primarily, they go to the pelvic bones and to the lumbar vertebra, so this is usually covered in a pelvic MRI scan. And the main imaging modality is bone scan, though PET may be more sensitive. Here's just an example of a sclerotic bony metastasis from prostate cancer. You can see it on CT, definitely, but it's a little bit subtle, and if you're scrolling really quickly through the CT, you can easily miss that. However, the same thing on MRI, you see normal bone marrow, you see the sclerotic bone on the outside and normal bone marrow inside, whereas here it's all very dark and there's no normal bone marrow. So that really is a little easier to see on MRI. And this is with contrast, just showing the area enhancing. This is just a little example regarding bone scan. Bone scan has some pitfalls as well. This is an MRI of a patient. At that time, the bone scan was negative. I saw a lesion here and I told them there's a little suspicious lesion, not little, but there's a suspicious lesion in the pelvic bones. And they did a bone scan. They said the bone scan is normal. Okay? 6 months later, it lit up on the bone scan. And it was a metastasis. So I don't know, maybe Professor Bocher was here, maybe because of its proximity to the urinary bladder with some shine through, or I don't know why it was missed on the initial bone scan, but the pelvic area is kind of a problematic area because of the urinary bladder. So you need to, if you see something really suspicious, stick with it, even if the bone scan is negative. So like we said, we can see all of these things with T2-weighted imaging, a full one-stop shop evaluation of the patient with prostate cancer. So we perform the examination with two central portions to it. Okay, we have what we call the pelvic portion, which looks at lymph nodes and bones. And this is based on axial T1-weighted images from the bifurcation of the aorta through the pelvis. We're looking for lymph nodes, for bony lesions, and for residual hemorrhage in the prostate gland. And then we do the main part of the examination, which is the axial T2-weighted images with or without diffusion, contrast, and so on and so forth. Oh, I'm sorry. Usually, Hadassah, when we perform this part, this pelvic portion, we also add an axial T2-weighted fat suppressed sequence. And this can help us both with characterization of bony lesions. Sometimes they're cystic, and we'll see them on that specific T2, and also help us look at lymph nodes. And then we have what we call the prostate portion, which is the bread and butter of the examination, and it is small, remember these words, small field of view, high resolution examination of the prostate gland in axial, coronal, and sagittal planes, usually T2 weighted, and we're looking for the dominant tumor to evaluate the capsule and evaluate the seminal vesicles. Pitfalls, okay, not a perfect exam, that's for sure. Prostatitis is one of the biggest pitfalls of prostate MRI examination. Prostatitis can cause low signal intensity areas in the peripheral zone of the gland. Prostatitis can also cause elevated PSA. So it is one of our big enemies, though it does look a little bit different from tumor. And we're starting to learn that probably on diffusion-weighted imaging, prostatitis doesn't give as low signal or as restricted diffusion as prostate cancer. Hemorrhage is a problem, and post-treatment changes. So here's an example. We can see a prostate gland, central and peripheral zone, and a low signal intensity area on the left side in the peripheral zone of the prostate gland. Okay, what is it? Well, it could be cancer, it could be prostatitis, it could be hemorrhage. And remember I said at the beginning that the T1 weighted images are not very high, they don't give us a lot of information. This is where they give us information. On the same images, on T1 weighted images, we see clear, significant residual hemorrhage from the biopsy in this patient. Okay? And then when we rescan the patient following 6 weeks, you see that that area, there is a cancer on the right side, by the way, okay? But you see that that area of low signal on the left side has resolved, and so has the hemorrhage. So, hemorrhage is an easy one to deal with. Make sure you have T1 weighted images to look for residual hemorrhage, which can cause false positive findings on the prostate exam. We usually wait at least 6 weeks from biopsy. This is difficult for patients. The patient is diagnosed with prostate cancer, they go to schedule, and our secretaries say, you need to wait between 6 and 8 weeks from your biopsy. They say, no, but I have cancer. Well, we need to remember that prostate cancer is usually a very slowly developing disease. Keep them calm, wait the 6 to 8 weeks, because otherwise you may run into significant problems with post-biopsy hemorrhage, which can cover tumor, and there's no point in doing the examination in this way. And if the patient is on aspirin, it can take even longer. Just to show you again, post-radiation changes the whole face or the whole shape of the prostate gland. And so this is what we already spoke about. We said that when we're doing staging, we need the highest possible resolution, so we'll use an endorectal coil. When we're evaluating a patient with an elevated PSA or a newly diagnosed prostate cancer, which is suspected to be very small and plan to go on no treatment after surveillance, do we really want to see every tiny little bit of detail? Or are we just looking for clinically significant disease. And for this, we need to understand tiny little bit about prostate cancer. Prostate cancer is a very wide spectrum of diseases, okay? It is, when you do a biopsy, you look at the Gleason pattern of the cells, how abnormal they are, well or poorly differentiated, and you put the highest and the lowest grades together. So if you have Gleason 3 plus 3, it's a relatively benign tumor. And if you have Gleason 4 plus 5, which will be Gleason 9, it's a much more aggressive tumor. And the spectrum ranges from microscopic low-grade prostate cancer, a microscopic focus on biopsy of Gleason 3 plus 3. These men, most of them, will live a very long and happy life with no problems from their prostate cancer and probably should not be treated. But at the very other end of the disease, which is much less common, you have large or multifocal high-grade prostate cancer, which can lead to metastatic disease and 1 man dead every day during the year in Israel. So we really need to be able to differentiate between these two diseases. Fortunately, MRI is a good tool for detecting larger and more aggressive cancers. Okay? When we look at the size of the tumor and the sensitivity of MRI, you see that the larger the tumor, the higher the sensitivity of MRI for detecting the prostate cancer, compared with smaller tumors, which in up to 70 or 80% we may not even see them. Tumors smaller than 0.5 centimeters, triple. And also with diffusion, we're able to see the aggressiveness. Okay, the higher the aggressiveness of the tumor, the more cancers were depicted using diffusion-weighted imaging. And here we can see that Gleason 9 cancers, 100% of them were detected with diffusion-weighted imaging. So we really have a tool in our hand to pick out between the clinically relevant or dangerous cancers compared with the probably less dangerous types of cancer which we may not really want to know about. So elevated PSA negative biopsy is a specific problem. The reason being that, of course, the larger the prostate, the more PSA it produces, the higher the PSA level. Most patients with an elevated PSA level will just have benign prostatic hyperplasia. The problem, though, is that when you take a patient with a large prostate gland and do sample biopsies of different regions of the prostate, there's more area to miss the tumor. Like over here in this apple. You can take all these samples of biopsies but miss the actual problem because the prostate gland is very large and you don't want to take 1 million samples. So we have a problem. And what we usually look for when a patient is referred for prostate MRI with elevated PSA is look for cancers in unusual places which the biopsy may have missed. Okay? So like central gland tumors, or anterior tumors, or very superior tumors, or very low down in the apex. These are regions that the urologist's needle doesn't always make it to, okay? That's what we're going to look for. Here's a patient with an elevated PSA of 10.8, that's pretty high, had 3 negative biopsies in the past. The last one was 1 year ago. The PSA is continuing to elevate, and we can clearly see a left-sided apical tumor, which has already gone through the capsule, okay, and was missed on biopsy 3 times already. This is an area, the low apex is an area which is problematic for biopsy. This is that same tumor in coronal imaging. And the same tumor with the diffusion-weighted imaging and contrast enhanced. Another patient, this is a 71-year-old man with a PSA of 20. That's very, very, very high. Remember, we start examining patients from PSA of 5, 3, 5, depending on how they raise. 3 previous negative biopsies. He has a huge tumor at the central gland. Look at the fusion-weighted imaging, how clearly it depicts the tumor. Okay, and this tumor is already extended beyond the capsule. It was a Gleason 9 tumor with extracapsular extension. So look for cancers, like we said, in unusual places. If there's no tumor seen on the MRI in a patient with elevated PSA, it doesn't mean that there's no tumor. There may be a very small, clinically insignificant 3 millimeter Gleason 6 cancer hiding in there, but do we care? Probably not. So if you have an MRI of a patient with elevated PSA, negative MRI, there's probably a very high chance that there's no clinically significant tumor in his prostate gland. And we checked this in a very small study. I don't know if Eli Ben David is here with me. He worked on this with me. And we examined 70 patients with elevated PSA and their MRIs. And in 13 patients, there was an abnormal MRI and a cancer found, and that was a sensitivity of 81% for detecting cancer in a patient which was not previously depicted on biopsies. Okay? But more importantly is that in 91% of the patients who had a normal MRI, there was no evidence of cancer. That's a negative predictive value of 91%. And the additional 3 patients, cancer was eventually depicted after PSA continued to elevate, and all 3 cancers were microscopic Gleason 6, non-clinically important cancers. So, do we need extra high resolution to look for a clinically significant cancer? Probably not. We can probably do these examinations, non-endorectal coil in a 3 Tesla machine. It'll be good enough to pick up a clinically significant cancer. Active surveillance, very similar. Active surveillance means evaluation prior to following up the patient with no treatment, okay? And what this means is a patient who has been diagnosed, and by biopsy, he has minimal disease, minimal non-aggressive disease, not planned for treatment. So in many cases, it's taught us the MRIs for active surveillance about the limitations of clinical evaluation, or how a biopsy can miss a clinically significant cancer. Here's an example of a patient who had clinically minimal disease on biopsy. He had Gleason 6 and 2 of 10 cores on the right and less than 5%, with a PSA of 8.5, and he was planned for active surveillance. What did the MRI show? MRI showed a very large tumor, central gland tumor. This is the ADC map, the diffusion. This is the contrast enhancement. This is the tumor. All of this is tumor, which was missed on the biopsy. Good thing he had an MRI done before they started active surveillance. So it has taught us the limitations of clinical examination, but it's also exposed us to many patients with minimal prostate cancer, which we weren't doing prostate MRIs before. So it's also taught us of what we cannot see. And here's an example of a 60-year-old patient, a BRCA carrier. Prostate cancer is much more prevalent in BRCA carrier patients. He had breast cancer 15 years ago. It's not fair to get both breast and prostate cancer in a man, but he did. He had a slowly elevating PSA over 6 years with 2 negative truth-guided biopsies. 1 year ago, he had a positive biopsy which showed minimal disease in the right mid-gland, and he was put on active surveillance. And now the PSA has continued to rise, and it's 21. Well, look at the right side of the prostate gland. Nothing going on. Completely clean. Peripheral zone on the right side. So the tumor, the minimal tumor that they found in biopsy, we don't see at all. But he has this huge, okay, that's on the right side. But he has this huge anterior central gland tumor, which obviously was causing the PSA to rise. And again, before going for active surveillance, it's a good thing to do an MRI. Here's just another example. Minimal Gleason 3+3 on the right, nothing on the MRI. Tumor on the left, which they did not know about. And it was, by the way, a Gleason 8 tumor. This was a clinically significant tumor. We see it on MRI, and it's a high Gleason. So when you do an MRI prior to active surveillance, okay, we may detect clinically important disease which was not detected on biopsy, so it's a good reason to do these examinations. Can we do them non-endorectal coil? Probably yes. We're looking for aggressive disease which was missed on biopsy. Okay, so probably yes. Non-visualization of tumor on MRI does not mean there's no tumor, but it probably means that there's no clinically significant tumor, and it supports the clinical decision and the clinical evaluation of minimal disease in the prostate, which can be followed and not treated. So, given these different clinical applications of prostate MRI, the ESCR has come out with guidelines for different prostate protocol examinations. Okay? If you have a patient with negative biopsy, as you can clinically follow them up and remeasure the PSA. If the PSA continues to rise and biopsy is negative, then you can do what they call a detection MRI. This would be a non-endorectal coil MRI, which is based on T2-weighted images and diffusion-weighted images. It can be done on a 1.5, but preferably on a 3 Tesla machine. And it's probably good enough for a patient with negative biopsy elevated PSA. Okay? If you have a patient with positive biopsy, it depends on what the current intent is going to be. Is this minimal disease on a positive biopsy and you're planning active surveillance? You can probably go to the same type of detection MRI. Here they say staging MRI, use an endorectal coil, get more information, because if you do find another tumor there, a larger tumor, you want to be able to stage it already in the same examination. But these usually have lower PSAs, and you don't necessarily need to do the portion with the lymph nodes in the bone metastasis, because if the PSA is low, there's not much chance of metastatic disease. And if the patient is expected to go to surgery or radiation therapy, do the whole full-blown protocol that I showed you before, pelvic portion, prostate portion, use an endorectal coil, use contrast, use everything you have to get accurate staging. So, do we have a virtual prostate exam? It's not virtual yet because of the endorectal coil. Maybe we will improve and be able to move to non-endorectal coils for everyone in the future. Maybe not. Thank you for your attention.
Merci. Thank you so much, Tamar, for your lecture. Always amazing.